Well, thanks so much for your time this afternoon. We'll just go ahead and jump right in. Today, we're going to be talking about stigma specifically with our substance use disorder population. So next slide. Thanks. So when we talk about stigma is an attitude, behavior, or condition that is socially discrediting. Oftentimes, the major influence regarding stigma with addiction are the beliefs about the cause and controllability. So it's our beliefs about what we think caused the addiction, and then what control the person has over it. We do know that the words that we use, those have been shown by researchers not only to negatively influence our attitudes towards people in active addiction and recovery, but they've also impacted access to healthcare and recovery outcomes. Research also shows that addiction is the most stigmatized condition worldwide, and it's one of the few health conditions out there that some members of the public still consider a moral or criminal issue. Side note, I had a few requests for updated farm pics on my lectures that I usually give. So here's our goat Squeak, who's probably judging me or stigmatizing me for something. Next slide, please. So stigma occurs at many levels, the public level, the private level, and the personal level. Let's talk about how. So we know that people fail to access or engage in treatment because the fear that they hold about what people are going to think about them. They don't want to be considered this negatively labeled addict. We know that medical profession sometimes fails to treat patients appropriately, like not using FDA-approved medications. We know that mental health programs will sometimes exclude patients with substance use disorder. They'll say you're going to have to get that treated elsewhere. Funding for substance use disorder treatment is insufficient to meet the demand. Drug users are sometimes viewed as unworthy of assistance, and so public policies to assist them are then sometimes opposed. Stigma is structurally reinforced by laws that criminalize drug use and permit discrimination. And then if patients have a criminal history because of their drug use, you've probably seen this sort of domino effect pattern exist with some of your patients. They have a hard time getting a job or employment or help because of what's happened in the past, but because of what's happened in the past, that's preventing them from getting ahead in their future. So it's just this vicious cycle, and that for some of them, that inadvertently kind of pushes them back to the past. Next slide. Thank you. So one of the defining aspects of stigma is often the person's belief about the causality of it. So what has caused this person to develop an addiction to substances? The old moral model line of thinking was really that addiction is just all about a lifestyle choice, right? These people are choosing to drink or use drugs in the first place. And so this type of thinking is often followed by contributing really negative labels to people. But instead, with this disease model, we recognize addiction as a disease, and specifically a brain disease, that you can't just will yourself out of it. And we know, that experiencing cravings is really experiencing suffering. Next slide. Thank you. So who is stigmatized in the addiction world? Well, frankly, all of us. So not just our patients, and not just our patients receiving medication for opioid use disorder, and not just their family ones, their family members, their loved ones, but also we are the providers that are treating these individuals, and specifically providers who provide medication for opioid use disorder. I'm sure along the way you've experienced the stigma when you tell people about your job, or in your smaller rural communities in West Virginia, getting your clinic up and running. I can imagine we could probably all share stories about what some of those battles were. Next slide, please. Thanks for being my mouse. Okay, so we're here to talk about stigma associated with addiction. Let's quickly look at the diagnostic criteria. I like that they really fit sort of nicely into these 4 categories. We can look at them from an impaired control standpoint, a risky use standpoint, social impairment, and then pharmacological indicators. Next slide. Thank you. What's not included, however, are really a few particulars. So things like the type of substance use, the quantity or frequency of being used, whether the substance is illicit or not. To me, this is an example of a stigma I see sometimes in Morgantown. So there's a culture of alcohol use that exists here where it is perfectly acceptable to get drunk in a hospital parking lot on a Saturday afternoon because it is adjacent to the football stadium next door, and that's totally okay. But we will then assign a different type of judgment or stigma against other people when they admit to having a problem with a substance or that they've developed a dependence to opioids. We will hold stigma for one, but not the other. Addiction results from the, so I like this quote just as a reminder to kind of myself and then others. Addiction results from the interaction of a reinforcing substance and a susceptible host. So it's not about whether you're smart enough to avoid it, or you're trying hard enough not to become addicted, or if you're a good person. We know that it's so much more than that. The reinforcing substance is the strawberry to my baby girl goat. Next slide, please. Thanks. So in working with this population, we have to always have empathy for our patients and try to understand where they're coming from and the unique treatment concerns that they're going to end up presenting. We know they have higher levels of shame and guilt. We know they experience higher levels of domestic violence and how much that gets in the way of them accessing treatment. We know they have a fear of legal involvement and specifically fear of CPS intervention, which really creates a potential barrier for them feeling safe enough to be honest with us. We know they have childcare issues, transportation issues, employment, just general financial concerns, and they're also at risk for other medical complications. And if I look at that list, I think about how many patients I work with who had to deal with so many of those treatment concerns additionally this past year. Folks who maybe didn't have childcare issues, but because of this year in virtual learning they did. Or folks that had actually a transportation system for them worked out, but the PRT hasn't been running this year, or the bus line was running a lot less than it usually were. So this year in particular, I think our population has had even more treatment concerns. Next slide, please. And so because of those often lead to potential non-compliance with their treatment. Some of those reasons can include they may be getting a lack of support from their support team, maybe insofar as their support team is encouraging them to keep using because that's what the norm is. We know they have concurrent medical issues, lack of financial resources, a drastic fear of withdrawal, the attitude of treatment providers maybe they've worked with in the past, and then some folks just don't like that daily reminder of having a chronic illness. And because we as providers are human, we can get really frustrated when our patients' humanness comes out themselves. It was not too long ago, I was in a treatment team meeting with Dr. Berry, and we were discussing a patient we have who continues to use tobacco despite having significant medical complications, and she has been on death's door more than once. And I was really expressing my frustration about this in the treatment team meeting with Dr. Berry, and he had to say, yeah, gee, Katie, it's almost as if she's got a tobacco use disorder and is having trouble quitting. You know, I know this stuff, and still I needed that reminder in the moment of like, oh, that's right, she's a human, that's why she's here. Next slide, please. Just have a couple of slides and some research I want to refer to. So there was a survey done by McGinty in 2015 in which they found that the substance use disorder vignettes were perceived in a more stigmatizing manner than the mental health vignettes. In a 2016 national survey, a large portion of the surveyors viewed individuals with opioid use disorder as lacking self-discipline. They believed they should not have equal rights to employment, and overall they felt they were blamed for their addiction. Next slide, please. Thanks. Let's look at research specific to healthcare workers and other professionals. So a review of 28 studies that looked at healthcare professionals found that some providers had stigmatized beliefs about their substance use disorder patients, and specifically viewing them as poorly motivated, manipulative, violent, and would potentially avoid working with them, which of course, that just adds to that vicious cycle of causing those patients to not want to seek out help to begin with. There's also found to be a general stigmatizing attitude towards people with opioid use disorder among professionals that work in public safety, criminal justice, housing, and child welfare. That's problematic because those are all agencies that so many of our patients interact with on a very regular basis. Next slide, please. Thanks. So finally, there's also a few studies here that are looking specifically at stigma towards patients receiving medications for opioid use disorder. I'll just kind of leave those up for you to look at. To me, the good news that came from the slide is that there is some evidence that suggests that as clinicians gain experience treating these patients, they develop more positive opinions about the role of medications. I know the folks here at Morgantown can speak to that. We've had so many visitors come to our program to either sit in well, back in the day, sitting in person in our groups, and now they're Zooming into our groups. But you know, a lot of those visitors had initially expressed their hesitancy about what medication-assisted treatment could really look like. But after sitting in on just a couple of group sessions, their opinions changed so much to the point where they decided they wanted to open up a clinic on their own. So being able to have that experience firsthand is so vital. I know some of you have also, invited visitors out to your treatment centers as well, and we really appreciate that. That's one more way that we can address that stigma. Next slide, please. There you go. So why does reducing stigma matter? Because we know that one of the main barriers to seeking and receiving help is stigma. And so what is the role of the treatment professional? You know, us on the call, how do we help stigma? And we can do this a couple different ways. We can help influence stigma with patients by helping them to reduce their shame and guilt that they experience, offering moral support, respecting their confidentiality, adopting a non-judgmental yet accountable stance at all times, treating the patient like any other patient with a chronic illness, and also always be advocating for them, advocating in and out of the office of what we can do for this population. We can also influence stigma in the public by providing education about substance use disorder as a disease and sharing stories of success. Sometimes I get on a little bit of a soapbox on, I feel like the only time we see stories about people in recovery on the news is when somebody's gotten arrested for a DUI or a mugshot showing up somewhere. I would love if we did that same kind of news bulletins about, you know, when folks in the news ended up celebrating a year of sobriety, 5 years of sobriety, etc. And then we can also influence stigma with ourselves by being aware of our own biases, working on our language, evolving with the recovery field, and finding support for transference issues that we're all going to face. It's the beauty of, I'm so grateful for the treatment teams that I get to participate in here at Chestnut Ridge, because I've got people I can go to when I'm struggling with the transference that I'm going to have because I'm just a human. Next slide. Talking specifically about language. So examining the language we use, not just when we're talking to our patients, but also when we're talking about them to others, if it's other members of our treatment team, if it's talking about patients on a echo call, you know, all of these can be helpful in the destigmatizing process. We want to move away from former labeling words that we use to more objective language. I always tell my patients that they have earned the right to use whatever language they want to use to describe themselves. I'm not going to use the term alcoholic or addict, for example. I'm going to say that they're a person with a substance use disorder, and I may talk with them about why, you know, what are kind of the benefits of changing that language. Again, at the end of the day, I'm never going to tell them what they should or should not call themselves, but just talk with them about the process of stigma and how little things like changing our language, you know, how that can help change the face for it for others. This is our rescue Potbelly Pig Spork. I said that he is not dirty, he is positive for mud. And I told my husband that, and he thought that was the worst joke ever, but I still left it in. Next slide, please. Thank you for the smiley face, Beth. I don't know how, I have no idea how to do that on Zoom. So to wrap up, I wanted to point you in the direction of the sometimes terrible and sometimes wonderful internet, where there are a lot of people coming together to address stigma. And I want to highlight a couple of those programs here. You may have heard of Shatterproof, or you may actually be working with them yourself. They set up a pilot program with 5 states, including West Virginia, to create a database called the Atlas database, I think, for treatment programs. Their hope is to create a sense of transparency with these programs. They obtain information straight from the patients, insurance companies, and the program themselves, and create these. So Shatterproof is a national nonprofit organization designed for ending stigma and helping those with this disease fully recover. They provide ways for people dealing with addiction and their loved ones to connect, receive education, and find evidence-based treatment. And they also advocate for policy change both on the state and federal level. Next slide. Thanks. Another organization is called the SAFE Project. SAFE Project was founded in 2017 by the Winfelds. They lost their 19-year-old son to an opioid overdose. They wanted to create a program, a movement really, that was unifying, nonpartisan, and evidence-based. They have a pledge on their website that you can sign. It's your commitment to contributing to the No Shame movement. And again, they're designed to support actions that combat stigma for mental health addiction. They provide information for the community, trainings, links to appropriate treatment, and then same thing as shatterproof advocacy for supportive legislation regarding the addiction crisis. And then last slide. So this quote up here came from Daniel Raymond. He was the previous policy director for the Harm Reduction Coalition. So rather than getting angry at people who use drugs because they don't do what we want them to do, let's try to understand why they do what they do and work with that. And for me, the flip side of that is also to try and understand why folks in society have a strong stigma view about addiction and work with that. I have a history of being intolerant of the intolerant people, and that's not going to get me anywhere and making any kind of headway with them. So I got to meet them with where they're at if I'm expecting them to meet my patients where my patients are at. And that's the last slide.
Thank you so much, Katie. This is such an important topic, and you always do such a wonderful job presenting it.
Thank you.
Katie?
Sure.
Oh,
Heather, was there a question?
I just wanted to make a comment. As soon as Sarah...
Your comment sounds super fancy. It's like you're making this comment to the world. I love it.
Sarah's sitting in the same room with me, and her sound was not muted.
I love the echo. It sounds cool.
I'm hiding now. She's gonna hide.
She turned her camera off too.
Leave it to us. Leave it to us. I wanted to make a comment on your last slide. The picture was the bomb. Like, I love the little pig.
That's my compassion. If I could just hold a little pig all day, like, who can be upset with other people or yourself when you're holding that thing all day?
What a perfect way to demonstrate.
Thank you. Thank you.
But I love that.
I appreciate it. Thank you. Thank you.
And your presentation was wonderful.
Well, thank you. Thank you. Mitra specifically asked for those updated farm pictures. So
those were fabulous.
Yeah. Thanks.
I'm a huge fan of farm animals, and they're so cute. I always have to request a new set of them for each time you present. Thank you.
You know, kudos to everybody on the call. If I just think about the last year in terms of what we have tried to process together as our own Echo family through the pandemic and how we've had to quickly adapt what our treatment looks like for our patients. You know, at some point, somebody could have said, this is just too difficult. I'm going to throw in the towel. I don't have the time to try to figure out a way to turn things around for what's best for our patient. And nobody did that. Everybody just rolled up their sleeves and said, okay, this is a group we need to help because they're going to be stigmatized in other ways throughout this pandemic this year. So how can we still remain helping them at all times? And so I appreciate every one of you on this call.
We appreciate you too, Katie. Thank you.
No problem.
Any comments, questions, thoughts anyone has, feel free to unmute or chat in. I can read it out loud to everyone as well. Feel free to bring in some examples, maybe personal stories you've had and experience with patients as well.
Here's a question for the group. And it has to do with, it was good to see that you listed fear of CPS on there. And in my practice as a primary care PA in the past, if I have a patient who I'm going to make a CPS report on, I usually tell the patient, and I guess over the years I have felt that was, even though I could do it anonymously, that it was important for me in my relationship with the patient to explain why. And most of the time I think I've done that. And so I'm going to ramble a little bit here, but it's become apparent to me in working with within the MAT program that is a real big source of anxiety for people for really good reason. I mean, partly to do with stigma and judgment and fear that they won't, get a break just because they take Suboxone, you know, that they'll be judged as being a bad parent. And I've found myself, I can't say that I've been in a position where I thought I should have called CPS and I didn't. But recently I've been, because of some circumstances for people within our program, I've found myself wondering about, gosh, how do you walk that fine line of supporting people in their recovery, not stigmatizing them, recognizing that that CPS would be terrifying for anybody, but that stigma adds an extra layer. And then would you talk to the person about it if you were to make a report? So that's kind of a lot in one thing, but I've never heard us talking about that on ECHO before in great detail.
Jennifer, that is a great question and topic. I've got thoughts on that, but I'd really love to hear from the group first. And I also think that could be a potential follow-up, like totally separate kind of ECHO presentation on, you know, what's the, you know, how to best handle that. So it's a fantastic topic. But yeah, let me first put that out to the group. What are your all's thoughts?
So I think your last question was, if you're going to make a report, do you talk with the client about that? Was that the last question you asked?
Yeah, that was the last one.
So what I usually tell students that I'm working with is, if it is safe to do so for you as the clinician or as the provider, if you feel like you have a good rapport with that client and it is safe for you to do so, then it is best to be open and honest and upfront about that, because that gives them an opportunity to grow from that experience, talk with you about it, work out any issues that it might cause between the therapeutic relationship. But there are some times where if you make a report, then that person might not be so happy about it and might put yourself in danger. So those are just my immediate thoughts about that. I don't know what you guys think.
One of the first things I tell our clients is that we are mandatory reporters, and if we're seeing things that that cause us to be concerned or worried about their children, we are obligated to protect their children. And so they already know that once they start the program. And then for example, if someone's early in recovery, relapsing, using in front of their kids, and they tell you about it, and they know and you know your kids are neglected, you know, I tell them, like, we're gonna have to report you. Now, fortunately for us, most of our clients already have CPS involved with them before they come. We've only had to do that one time with a parent. And it was very difficult because we were worried about losing that rapport, losing that trust. So we did pull her aside and tell her, hey, we're going to have to say something because your kids are in danger. And it worked out okay. She stayed with the program for a while, and then kept relapsing. But I always have to think, if we don't report, what's going to happen to those kids? Because so many people in our program say they wish someone had protected them when they were growing up and no one did.
Somebody once explained
Maybe just
to
a
me,
tangential. Go ahead. I'll be
You
fast
first.
then. Just tangential observation is that CPS is also a very stigmatized profession, especially in West Virginia. So that it's interesting, that reciprocal relationship there.
Such a good reminder. Phil, you were going to say something?
One thing that was always taught to me whenever thinking about or making a referral to CPS was, it's our job to report, it's not our job to investigate. And so kind of explaining that too to the client, that, hey, you know, too, if it's coming from us and the parents feel stuck, like they don't know what to do with their kids, they've tried things, they've tried everything within their power, and it seems reasonable. Sometimes too, it can help them if we make the referral and we have that conversation with them. It might help them get into treatment a little bit faster, even though it's not always the best for the parent because it can put them on scrutiny. There's actually a conversation Katie and I had on Friday about a patient, and the therapist brought it to me. Anytime CPS is brought up, I typically seek consultation, just because you can get into some ethical gray areas. So that's kind of a safety net for me as well.
I was just going to say I have a kind of an interesting advocating culture for patients who are involved in CPS in the co-clinic. And what I do is tell them that I'd be happy to write a letter for them to give to CPS, or have the case coordinator write a letter about their standing in our program, to kind of advocate for them. It emphasizes the importance of being a good parent, but also saying, if you're working on recovery, maybe we can produce a nice letter for you. So it kind of changes the tone of the group.
That's great. A couple things I want to say. First of all, I agree with everybody's sentiments on here about, reminding them that you're a mandated reporter ahead of time and relying on the treatment team to help you with that. I like what Beth said about, if it's safe for you if it's safe for you to do so and safe for the other people involved in the equation, that there can be a lot of benefits in being honest with your patient about making that call. I know for me, it gives the potential opportunity to kind of model for them how to handle conflict. Okay, your feelings are hurt and you have a right to do that. Let's talk through that. How can we work through that together? How can we, honor the feelings of anger and hurt that you have, and still us find a way to stay connected to work through that. I think sometimes some beautiful therapeutic work can come from that. I'll also give my incredible shout outs to Tony and Dr. Bo on the call. They've been, two of maybe some other people on this call have been working with the state to try to change up some of the language with DHHR and CPS maybe about, just how to change the way that they're talking about MAT and the way they had included or precluded in the laws about getting kids back, and they both have done a lot of work with that. So thank you to both of you.
Thank you all so much, and thank you, Katie. Any other thoughts, comments, questions? Still to this day, I always remind myself that silence is good. Dr. Bo, was there something?
Oh, I just wanted to say, I actually really love that idea about having a conference on CPS and how we should interact and thoughtful ways in which we can communicate with our patients about it. Just so we're all on the same page and kind of know how to navigate that situation, because it does come up and it's very uncomfortable.
Absolutely. I think absolutely we could have probably at least one, if not a couple of echoes on that. And I also know there were a couple of us on this call thinking about educational and training opportunities we want to get involved in this year. And one of them was, putting together some presentations and trainings for CPS. So if anybody wants to participate in that, I'm sure we would love outside help.
I would love to help you with that.
Oh, great, Dr. Bo. I will. Beth Witter, you're on the list. If you're on the call, if you can remember to include Dr. Bo on that. And I don't know if Brianna Shepherd's dog wants to help with the presentation. Who I saw.
You know, Brianna would.
Yeah.
Yes, Daisy and I are both for this effort, and we will help however we.
Perfect. Thank you so much.
I love it. Thanks, guys. And I'll certainly put down the CPS topic on the list as well. And we can feel free to reach out to me as well if I can help maybe schedule a topic for the second half of the year with a didactic on that.
Awesome.
Any other thoughts, comments, stories you'd like to share with the group? Alrighty, well, I'll give you guys about 25 minutes back to your Monday. That's a good way to end a Monday, right? But I guess we'll just jump right into the announcements for next time. So our next time we'll meet is on February 22nd, and we're going to have a guest speaker kind of discuss her research topic that she's been working on. And the topic is technology-assisted prescription opioid education. So keep an eye out for that reminder as well. And thank you so much, Katie, for another wonderful presentation. And thank you all so much for joining today. We'll see you guys next time.